there's so much out there about AI, but I think one thing that's really important to think about when you think about AI is it's entirely dependent on the data and the systems that it works with. So if the data is not accurate, the AI isn't going to be great. So initiatives like CORE, where we're looking at creating common definitions for data, whether it be in a claim transaction, the provider data that goes into a credentialing system, AI is going to be largely dependent on that information. So I think I would encourage the industry to look out for initiatives that are working to improve data accuracy, which is only going to make AI function better. And I think similarly along those lines, one of the things I have seen a lot recently in the industry is concern around technology, or the belief that technology is going to solve all of our problems, technology like AI, FHIR APIs, et cetera. But again, that underlying data is going to be so important, and it's just not a technology problem. We have workflows, there's people involved, there's behavior change involved. So I would encourage the industry to look out for opportunities where you can engage to create whole solutions that are looking at not just the technical challenges, but the business challenges, the workflow challenges, and take that all together. And organizations like the CORE initiative at CAQH are doing that.
So we see that over a period of time, the line between the payer and the provider will blur. So a lot of payers will start acting as the provider. You can see with United Health Group, they are one of the largest providers also now in the nation, which very few people know, CAQH permanente. So that is going to become a bigger phenomenon, and the RCM vendors need to prepare for that.
Yeah, I think to me, prior auth is something that, again, it's top of mind for most folks because it's a very challenging thing for providers to deal with. But there's some interesting legislative things happening. Vermont, for example, just recently passed a law that prohibits the prior auth process. And so I don't know how far it's going to go, and Vermont's usually on a sort of an outlier, if you will, in terms of their state laws as it applies to healthcare. But it's something to pay attention to and something that we're watching very closely.
That's a great question. It's so often you talk to revenue cycle companies and I'll ask them what they're doing. They'll say, well, we've got great experience, we've got great people. And they're all kind of doing the same thing. They talk about denial trending, but it's not about denial trending. I liken it to driving down the freeway, looking in your rearview mirror. That's great if you're on a straight road, but if you hit a curve, you're in trouble. And we all know healthcare brings you a curve. So it's important today that you don't think it's just denial trending. What we do is we actually bring forth denial prediction and be able to be prescriptive about it. Denials are going to happen, but you don't want to be touching them multiple times. So if you can actually trend the data and then start doing denial prediction and be prescriptive with your fixes, that's when you see velocity revenue and true revenue performance.
So everyone at this conference, I think, understands that change in healthcare takes a long time. Nothing happens too quickly. So I'd like things to happen more quickly. I think one of the things that we're seeing is the momentum of some of the things that are starting to change. I've been in this business a long time, and I've seen changes in the last 5 years greater than what I've seen in the last 20 years. So I think providers are really starting to embrace different ways, at least on the patient collection side, to collect from patients. We've seen that with our integrated financing solution for patients, of which more and more hospitals are taking that on. And frankly, I think that is the way most hospitals over time are going to start collecting from their patients.
I would change, I think of the RCM process a lot like a manufacturing plant. And if you think about manufacturing, it's all about automation and then strategically inserting people into the places where there can't be automation. I think sometimes in healthcare, we think of it in the opposite way. We think of all the people and then trying to insert automation. I think if we could flip that script around and think of all the things we can automate, and then strategically placing our people, the Swedish people say they can't afford to waste a brain. We can't afford to waste a brain, so let's use people strategically in those places that we can't automate, instead of thinking of just the people we have existing and then trying to fit automation into check a box.